Good afternoon, everyone. And first of all, thank you very much to the organizers of this absolutely relevant Congress, Medicine 2044, that is hosting here in Zaragoza, my city, close to Phoenix. My city where I was born, study, live, and work. It is particularly amazing for me to be here. Thank you, Professor Nadir Arber and Angel Lanas, for giving me this exciting opportunity to participate in the Congress with the principal aim to discuss how medical innovation will transform future healthcare worldwide. My name is Dolores Isla. I am the head of Medical Oncology Department at University Hospital Lozano Blesa here in Zaragoza, Spain, and I'm very delighted to chair this special lecture, the session special lecture by the Congress President, Professor Nadir Arber, and the presentation of 5 selected abstracts. Nadir Arber, an outstanding researcher and physician, and it is my pleasure to share this session with Jaroslav Regula, that is going to continue with this session presentation. Jaroslav.
Thank you. I have a great pleasure to introduce Professor Nadir Arber, long time friend of mine, and he is chief of Tel Aviv Suraski Preventive Center and co-chair together with Angel Lanas of this Medicine Future 20-something for many years now, which is a very visionary congress that is repeated frequently, every 1 or every 2 years, which is a great achievement. We are all very excited. Professor Nadir Arber is also interested in screening for cancer, and the talk will be concerning colorectal cancer prevention. So, Nadir.
Yeah. Hello, good afternoon, and I would like to thank the organizer for inviting me to give this talk, and also for keeping the traditions to keep the best lectures at the end in order to keep the audience. So thank you. And I'm going to tell you about the best therapy of cancer, which is early detections and prevention. So I do not believe in the ostrich strategy. I do not believe in the monkey's philosophy. If we ignore, it is not going to disappear. This is the numbers of 20 million new cases in 2022. Half of them died. The numbers in 2040 are going to double. Cancer is a major health concern, and despite the major advancements in cancer therapy, still, and I'm going to show you, the best therapy is what we are advocating. So 1 out of 3 women are going to have cancer. Here, the decisions is more difficult. I mean, it's easy. If you support Real Madrid, you will choose Messi, and the other way around. But if you are coming from Real Zaragoza, maybe both of them. But 1 out of 2 men is going to die from cancer. So prevention is the key. Just see this little small egg, 500 milligram of hammer can destroy it. But if the monster erupted, then it's too late, and you need a lot of aggressive therapy that in most cases do not help and has high price. It is not my idea. It actually came from a Spanish philosopher, Dr. Rabbi Moshe ben Maimon, Harambam, who lived about 1,000 years ago, said that the best physicians is the one make early detections. So I'm very proud of this Spanish philosopher, also happened to be Jewish, until I came to China. And then this Chinese asked me, when did this clever guy live? I said, who? 1,000 years ago. He said, 1,000 years ago. Most probably took it from Hang Di, who said exactly the same. The superior physician's health before the early budding of the disease, but he lived 2,500 before Christ. And at the same time, also, the Chinese told me, I don't know if it's true or not, but it doesn't matter because it's a good story, that in China, the people pay the physicians as long as they're healthy. When they became sick, physician failed, they stopped paying. I do not know if it's true or not, but it's a good way of thinking. So, and this is something that it is important to understand. How can we? So this is a man and in shadow. This man is in perfect health. He just climbed the Kilimanjaro. It is too easy. He is aiming for the Everest. And then, but something inside, because when cancer at its first stage doesn't have any symptoms, and this is a time to intervene. So I was born here, and I'm going to Dover. I'm going to start with the disease. Do we have a pointer, or we don't have a pointer? Oh, I'm going to die from a disease that will start to next year, that will cause to the disease that you're going to diagnose, and depends how good are my doctors, and I have the best doctors in Tel Aviv Medical Center that will lead to my death. So when we speak about preventions, we speak about secondary preventions. We have the disease, but we still no symptoms, and we're trying to identify these patients in order to intervene and prevent the endpoint. If you're not going to prevent the endpoint, no need to do screening. And there are some cancer that it says, and I'm going to address it. We also associate with primary preventions, lifestyle modification, and also going to address it, but also are important in order to prevent this disease. So obviously, obesity is a major health concern. I developed the ultimate physical activity that can prevent obesity. Look at it, it's very easy. Weight loss is guaranteed. Whenever you are offered food, you just have to do this. You know, there is nothing more frustrating when you tell a joke and nobody is laughing. So please, but it is true. Try it whenever you offer food and you nod with your head, it's 100% guarantee to lose weight. Obviously, not smoke, not to drink. And when I speak about physical activity, this is not what I mean, not that. But again, remember I was in China, then I went to Japan, and if he can, each of us can exercise. Look, it's just a matter of will. Exercising is as important as quitting smoking. It is very important, and we have to advocate it. So let's say that somebody is health conscious. He would like to prevent cancer. So he's going to his GPs and tell, I want to prefer prostate cancer. So he's sent to urologist. The urologist is telling to send PSA. Also have to do free PSA and the PSA velocity. Then it's a woman and she's coming to the GP and asks, I would like to prevent OBGYN cancer. So he's sent to a gynecologist, to a pap smear, HPV DNA, vaginal ultrasound. And then she would like to prevent skin cancer. You're going to oral plastic surgeon, dermatologist. You have to do it with a dermoscan. And then you would like to prevent breast cancer. So you're going to refer to a breast surgeon, oncologist, you do mammography. And then if you want to go to gastroenterology, ask Angel, the length is very high. You have to wait months until you have an appointment. If you're able to do everything a year pass, you have to do everything to begin. Ladies and gentlemen, it does not work. And this is what I tell my patients. Treat yourself as you treat your car. Once a year, we have to do a checkup. You go, even if it's a brand new Mercedes, you go and you have check. If you have to check for one place, we'll check for water, one place to check for oil, one place to check for pressure in the tires. Thank you, Tzipi. One place, it is not compatible. If we have to do it one place, then we do it. And this is exactly the same for us. So I'm working in a hospital, but I established the first health home for the healthy people, where we can try to prevent and to early detect diseases. One-stop shop. The patient is in the center. Everything is coming to him. We have everything. Plastic surgeon, passing HPV DNA, gynecologist, urologist, oncologist. We have everything. We can do it everything within 2, 3, 4 hours, depends if you're male or a female. And if we found something, we can do it continue. Because sometimes we lose patients on the way. So if we can find something, about 1 to 2% of the health questions, we can continue. Most of the time, we can complete the evaluation. So this is a way to go. And you understand, it's not easy to find cancer. Let's imagine that we are looking for a man in this audience. Where is it? Dr. Shapira? Oh, you know. he is not a woman. It was not easy. So, but when you have much more, remember that in the healthy populations, cancer we can find about 1% of the populations. So this is a true positive. We have also false positive. We have non-conclusive. It's not an easy task, but we are doing our best. So what we are doing in my center for Integrated Cancer Prevention Center, so we're screening for 12 most common cancers that are responsible for 80% of cancer mortality. We are working according to guidelines. We don't do chest X-ray to find lung cancer for all of them. We just load low-dose CT to those at increased risk. What about prostate cancer? There is a hypes and rise and fall of PSA, but when we do it, as we do it in the center, when the patient is checked by urologists, and we're checking for PSA, free PSA, the ratio between them, PSA velocity. In borderline cases, we can do MRI or 4K or ISO PSA, and at the same time, we do also what people do not understand the difference between screening and case findings. I would not invite people to come to check their testicles, but they come to urologists for different reasons, to check for prostate cancer. So at the same time, it's just so easy to check the testicle to see it's cancer. This is the case finding. So we also are doing this. There's also, again, there is a big dilemma to screen or not to screen for thyroid cancer. We are not going to go into it. Personally, I believe that knowledge is a strength. So I would like to know, and that's what we do. Usually we palpate the thyroid, and if we find something that is suspicious, we can do ultrasound on the spot, and if needed, FNA. But we are trying to do, as we move into 2044, to do a precision medicine. We have used all kinds of models, as discussed. They became too expensive, so we moved to them, but apparently they are not even more expensive. So we are using some kind of old models that still exist. So this is a classical Tyrer-Cuzick model for breast cancer. I like it because it gives the highest score. And in Israel, it is in the health basket that if a lady has a chance of breast cancer for more than 10%, then she is entitled for screening MRI. So we do it, but then it is easy. Everything that in life, in medicine, is simple, is going to be successful. So you can just checking here for a few simple, like age of menarche, age of first, a number of pregnancy, number of children, etc. You can calculate the risk. And as you can see it here, the penny drop for this woman, she understands that actually she has a twice as risk as the normal. Then she is more tolerable and more willing to accept screening. Or as you can see it here, the same. We also developed the Leshno-Moshkovitz Arbor scheme for colon cancer. There is a lot of them. Again, simple markers, and when we come to number and then people understand the likelihood of screening, the likelihood of having cancer, then the adaptations is better. And we have for other cancer as well. Genetic is very important, so when it needed, on the spot we can do genetic testing. Usually you can send it for panels of 80 genes that are associated with cancer. This is a result of 600 patients that attended. We found this is a mutation that we have found, and in about three-quarters, about two-thirds of the cases, when there are some family history or personal history of a few cancer, we did find a mutation that helped us in screening and surveillance. We did a whole genome sequence, including mine, in 50 patients. I was surprised that we did find some genes, as you can see it here, that actually change we were not aware of it, not based on the family history. Maybe now when it's going to cost, as we heard earlier this morning, $100, $200, $300, maybe it will be part of the general practice of anyone that is coming. So what are the results of our integrated cancer prevention? We just published a paper in JCO. There was about 10,000 equally numbers of men and women, and we found cancer in 1.5%, as you can see it here. More than one cancer in 41, and this is important. 57 died, 20% mortality. It tells us that actually you do find cancer at an early stage, because you remember that in the first slide in the introductions, mortality was about 50%. So it's not one-to-one, but still having a mortality of only 22% tell us that we do find cancers at an early stage. So we had published this in JCO finally, and it was not a tough combat to convince the oncologists that the way to screen is one-stop shop. As said, if you're going to different places every time, it is not going to work. And we did find in 73% were in early stage, and there is no good data to compare, but we compare our results to the United States with the stage that we had found, and we did found patients at an earlier stage than usually is accepted, again showing that it is working and we can find cancer at an early stage. But always you have to learn from your mistakes. So there was so this is a detection rate of cancers in our center. And as you can see here, green, cancers that were detected during the index visit. In red, cancers that we have missed. And in blue, cancers that develop more than a year. And as you can see it here, this is a range of cancer that was detected more than a year. And this is actually what I tell my patients. Up to 364 days, it's my responsibility. 366 days, it's your responsibility. So patients also have to take responsibility. I think this is, still there is no data, because this is a first and only integrated cancer prevention center that usually if you're doing every year, this is the time that makes sense, and you should do it once a year. I think everyone can devote a few hours once a year, exactly like we do with our crowds. We can look for the Kaplan-Meier survival curve, and as expected, those cancer that detected in the center did significantly better than those who the cancer was diagnosed more than a year later, and those who have missed. And maybe, and I'm not trying to give excuses, and I'm going to address it soon, but sometimes, we do have aggressive cancers that developed very fast, so maybe it was not our fault, and maybe, especially in breast cancer, sometimes there were very aggressive cancers that developed within a few months. So if we are going to this, so we do, I think we should learn from our mistakes. So only 17 cancers were missed, so if you think about 10,000 people, it's not much. 8 of them were out of the scope of the screening. Brain, pancreas, kidney, male breast, we have no screening recommendations. 3 were missed because of a young age. We do see a change in the age of cancer. It's becoming younger and younger, and we do not exactly know the reason for that. For colon cancer, the age of screening is 50. I advocate to my patients to start about 40, and even now in the United States, they reduce the age for 45. Most probably it's going to be reduced more, and when we are going to combine it with screening and all kinds of genetics and scores, we'll be able to target the exact population that should be start screening earlier. 6 were missed, 5 of them they were breast, as said, maybe because of it was aggressive tumor, and 1 was of thyroid. So I had a dream and it was fulfilled. I had this dream 20 years ago to have this one-stop shop for cancer prevention. It was not easy to convince my colleague, the oncologist. When we published this paper, I achieved it. And now I have another dream, whom I'm going to, with Dr. Shapir and her team, we are going to achieve. We are going to hear her and some of her students about the Pandex. A blood test can detect all cancer, pan-cancer screening test. So I'm not going to show you all this because they are going to address it, but it is amazing. One blood test, simple, that can detect all cancers and even detect early preneoplastic. Even they can detect polyps, adenoma in the colon. in summary, cancer is a leading cause of death globally. We just show you a prospective cohort study that span over 20 years with almost 20,000 self-referred asymptomatic healthy subjects, and it is working. By implementing evidence-based prevention early detection strategies, we can prevent more than 50% of cancers. Mortality was improved significantly because patients were identified at an early stage. Precision medicine and genetic testing are very important, and we are going to improve it significantly, especially when the next stage, what is going to happen, instead of coming to the centers that I've shown, the one-stop shop, people are going to come, we'll take a blood or whatever Dr. Shapira will decide. We'll tell the patient, do some internet read, eat something. After an hour, she tells us who should go home and come back after a year, and who is to enter the center to try to find the cancer. So it's maybe only 1 to 2%, but even if we take that only, she will have a specificity of 50%, then we can downsize the population by half, which has immense importance clinically and wisdom. So then always the question is, who is going to pay for it? So let's think that, can we go back a slide, please? This plane is going to land in Zaragoza airport. I know that you have a small one, but let's say, and then the pilot says to the tower control, emergency, we are going to crash. So bring all of the SOS, all emergency, police, fire, everyone. But then the pilot said, yes, but if I have some money, we can prevent the crash. Do you think that anyone in the Aragon government or whatever will say, we don't have enough money, we don't have enough resources? Obviously not. Everyone said, obviously, take the money, just prevent the crash of the plane. So ladies and gentlemen, every day, 4 to 5 747 jets are crashing because authorities said that they don't have money. We should try to raise our voice to prevent it and to try to prevent what this angel told to the others. Our authorities did not have enough money to sponsor my visit to Integrated Cancer Prevention Center. So what in 2044, when asked our students cancer, they said a rare event occurring in those who do not attend yearly checkup at Integrated Cancer Prevention Center. And this is the time to say thank you to our team and thank you to you for listening.
Thank you, Nadir. And we have time for a short discussion, 2 or 3 Q&A. And is there any question from the floor?
Usually I implement questions, but I forgot this time. Thank you, Angel.
Yeah,
You're a good friend.
Well, first of all, Zaragoza has one of the largest airports in Spain, right? So it's because it's actually a civilian and military airbase. And the second is, I understood that you complete the whole checkup of all type of cancer in 2-3 hours.
4 hours.
So because
men are simpler, but so we have less.
Some
women.
of the tests for early cancer detection is a bit complex, so it could be invasive. Colon cancer, for example, is a colonoscopy, or is just a blood test, or is a
No, you're right. So I advocate colonoscopy to all of my patients. We are doing it once every 5 years. So obviously not in the first exam, so we cannot do it on the same times. Some of them we can do in the same day, but not in the first visit. But you have to do it every 5 years. 5 to 10, I advocate every 5 years. So you're right, but everything else I have on spot. I have ultrasound, I have all the physicians, I have blood tests. Mammogram is just next door, mammography, CT next door, ultrasound, regular and vaginal inside. So actually, we have everything on spot.
How many patients per day?
60.
60. And are all paid by the Israeli government, or
So,
is a...
Not.
Okay.
No, we have a lot of other argument with my government, especially nowadays, but we have agreement with all kind of high tech. Now I'm living in the state of Tel Aviv, which in a way is different. So we have a lot of high tech, so they sponsor it. We have some time with some of the health HMOs, so we do kind of agreement with them. But you know, I've seen just walking inside to interact with the patient, and I saw an old couple, and I spoke with them and said, "How did you come?" They told me, "Nadir, you know, every 2 years we are going on our vacations abroad. This time we decided not to go to vacation abroad, but to come to your center. I felt bad about it, but I think they made the right decisions. Think about it. It's only not that expensive. It's cost a few $100, but it can save life." I think everything. I can just tell you a story. I was invited by the Singapore government. I just gave them exactly the same presentations, and they said that, I told them it's not cost you, it's cost saving. If you do this, you're going to save money. He said, excellent. We are going to offer it to all our citizens. And then I said, but how you are going to force them? He said, we cannot do it. We are a democracy, kind of democracy. Maybe the best democracy, because also the weakness for democracy, as we know in Israel. But say we are going to offer it free of charge, but if someone does not do it and have cancer, it is a problem. Exactly like when you buy a new car, you should insure it, but if you don't want to insure it, and it's stolen or something happens, it's your problem. So this, the way that we are doing, they are offering free of charge. If somebody doesn't know it, it's his problem. I think this is the way to go. Eventually, we understand that this is the best way to treat cancer, and it's also cost-saving. Thank you.
Yes, Nadir, I have a question for you. I think liquid biopsy is a key cancer screening technique, but up to now, with high false negative results and lack of standardization, and I think we need to improve the results, perhaps with the contribution of AI intelligence, artificial intelligence, or how to imagine this technique in 2044.
I think we are going to reach it sooner, and you should stay for Dr. Shapira lectures because you are going to address it. We also develop a liquid biopsy, which has a very high IUC, and if it's combined with the centers that we have, this is a way to go, because there is other tests, but you're right, for them, the healthy controls are not really healthy. It's somebody that's asymptomatic. When Shiran developed her test, it's based on the people that attended the Integrated Cancer Prevention Center, and the patients, they are healthy, and they do follow up. Cancer registry in Israel is very accurate, and we know if somebody developed cancer or not. So I think when you do it, her test, with our integrated cancer prevention, this is the way to go.
More questions? Nothing? Thank you very much. And we are going to continue with the 5 abstract selected presentations. And the first presentation is about integrating thermal liquid biopsy and machine learning for enhanced early diagnosis of malignant ovarian tumor, and the author is Francisco Javier Falcó Martí.
Well, good afternoon, and thank you for the presentation, and thank you for giving me the opportunity of presenting this project, which it is entitled, as you have said, Integrating Thermal Liquid Biopsy and Machine Learning for Enhanced Early Diagnosis of Malignant Ovarian Tumors. In this case, it goes in the line, as it has been commented previously, of an early diagnosis for a better prognosis. But in this case, I'm going to focus on a specific type of cancer, as it is ovarian cancer. To start with, let's comment the concept of ovarian tumors. Ovarian tumors are the result of an abnormal growth of cells within the ovaries, but they are not necessarily malignant. When they are malignant, we refer to them as ovarian cancer. And ovarian cancer is an important topic. It ranks third when we consider gynecological cancers, but it ranks first if we consider the ratio, mortality, and incidence. Obviously, there are some biomarkers for diagnosis, and there are different methods and techniques for this purpose. but they are not enough. They are not enough because ovarian cancer is usually diagnosed late, and as we know, this late diagnosis affects the prognosis. In this context, we think that there's a need for new diagnostic approaches, and here is where the methodology called thermal liquid biopsy emerges. In this line, we have set a main objective, which is to develop and validate a classification model based on 3 points that are thermal liquid biopsy, machine learning, and patient-specific variables in order to provide physicians with a tool for presurgical diagnosis of ovarian cancer, as well as assessing the effectiveness of this methodology, the thermal liquid biopsy, when we consider it for a diagnosis context. Regarding the methodology suggested, which is thermal liquid biopsy, it is just the application of differential scanning calorimetry to biological samples. So in this case, instead of applying differential scanning calorimetry as usual, for example, for analyzing the thermal denaturation of proteins, we are going to apply it to a biological sample, the whole sample, which in the case of ovarian cancer will be serum samples. With this technique, we obtain a thermogram, which is no more than the representation of the excess of specific heat capacity when we compare it from the compartment with the sample and the reference compartment. So we obtain a thermogram that is the key of our methodology. The analysis of this thermogram is the basis of the diagnosis method. It has been checked and visualized that there are differences in shape when we compare the thermograms from patients that are healthy and we compare them to patients that have different types of diseases, for example, cancer. But not only this, we have also realized that there are differences when the ovarian tumor is benign and it is a malignant one, and we can refer to it as ovarian cancer. So to analyze this type of thermograms, we apply machine learning algorithms, which leads us to develop ITLB models. This ITLB model contrasts with the iClean models, which are based on patient-specific variables. And our suggestion is to combine both methodologies. So we develop a ITLB plus iClean model. This is a predictive model for ovarian tumor malignancy diagnosis. The model we developed was based on a population that was formed by patients that had benign ovarian tumors and patients that had malignant ovarian ones. The model produced gave us a significant separation between the two states, and it also highlights the importance of the thermal liquid biopsy, because the coefficient with the highest impact on the result of the model is a temperature pair. These results were also analyzed comparing the different stages of cancer, so earlier and later stages, and we also compare these results with the classification made by physicians that usually classify in benign, malignant, and indeterminate categories based on imaging techniques. And here I want to highlight the indeterminate group, because in this case, we are including all those cases for which physicians do not really know what to say. So here our model has more to do, as it is able to determine successfully the malignancy in nearly 4 out of 5 cases. So in the line of these results, we have reached some conclusions, among which I want to highlight that the biochemical markers selected by the model are already used in literature, but their diagnosis is improved with the introduction of ITLB. ITLB based on temperature pairs improves this diagnosis, and ITLB plus iClean models have been shown to be a promising tool for the diagnosis of malignant ovarian tumors. These models are able to diagnose early and later stages, and they have shown their ability to overcome the difficulties found by physicians in this diagnosis based on imaging techniques. And to finish, with a perspective to the future, we consider that it would be interesting to develop these kind of models with different patient cohorts and to test them with different cohorts in order to assess their effectiveness in different contexts. So thank you very much for your attention, and I also want to express my gratitude towards my research group colleagues for their essential effort in this project. Thank you very much.
Thank you very much. We have time for one question. If there is some from the audience, please, there is a chance to ask the question. If not, thank you very much. So we continue. And the second abstract that was selected as the best abstract is will be presented by Jorge Paul, bispecific killer cell engager bike against TN antigen and non-tissue restricted immunotherapy for cancer treatment.
Good afternoon, and thank you for the presentation. As you have said, my name is Jorge, and I am a PhD student at Julian Bartos' lab here in Zaragoza, and I am going to talk about a bike against TN antigen. First of all, I will briefly talk about the natural killer, or NK cells, and as you may know, these cells have the ability to eliminate infected or cancer cells inside of the body through the release of cytotoxic granules with enzymes and perforins, or by the expression of death ligands. As NK cells are part of the innate immune system, their responses are not antigen-specific, and its activation depends on the balance between activation and inhibition signals that it receives from the targeted cell. In the case of cancer, these cancer cells try to evade the NK response by overexpressing the inhibitory ligands, for example, the MHC, but we can use some molecules like the bike to overpass this inhibition and reactivate the NKs. So what is a bispecific killer cell engager or bike? The idea is very simple. It's just a bispecific molecule composed by two STPUs connected by a linker. One of the STPU is going to recognize the tumoral antigen in the cancer cell to target the therapy, and the other STPU is going to bind to the CD16, that is one of those activation receptors of the NK cell. This binding is going to produce a strong activation signal into the NK cell that is able to activate it even in the presence of other inhibitory signals, as happens in the tumor. And at the end, it's going to produce the killing of the targeted cancer cell. And to end with the introduction, I will talk about TN antigen, that is the target of our therapy. And the particularity of TN antigen is that it is an aberrant glycosylation pattern and not a protein. So the idea is that as all tissues express glycosylated proteins, in theory, all types of cancers could express TN antigen. So this way, immunotherapies targeting TN wouldn't be restricted to a few types of related cancers, as happens with most immunotherapies currently available. So the objective of our work was to generate a bike targeting this TN antigen, and to do that, we used the 2D9 antibody that recognizes the TN antigen, and an anti-CD16 antibody that specifically recognizes the CD16A molecule on the NK cells, and not the CD16B isoform expressed by the neutrophils. So we designed, produced, and purified these proteins using standard protocols for mammalian egg production. We produced the bike, and also as controls, we produced the 2D9FC that has the same structure as an antibody, and the 2D9 STPU and the anti-CD16 STPU as controls. And as you can see here in the yield, we obtained them with a high purity grade. Then we wanted to determine if the 2D9 remains the ability of the antibody, the 2D9 inside of the bike molecule retains the ability of the antibody to bind to the target, in this case the TN antigen, and to do that we labeled a panel of different cancer cell lines. And as you can see here, in the case of the URCAT and the THP1 cells, the 2D9 bike produces a similar staining as the 2D9 alone, meaning that it retains that ability in the bike format. And as you can see here also, in the case of Raji, it seems to not express TN because there wasn't any labeling. On the other hand, the bike must also bind to the CD16 on the surface of the NK in order to be effective, and to prove that, we labeled human NK cells. And as you can see, the bike produces a similar staining than the anti-CD16. And finally, to prove that the bike doesn't bind to the CD16B isoform, we labeled also human neutrophils without observing any staining. Finally, to prove if the bike was effective, we did co-cultures of a TN antigen expressing cell line like URCAT with human NK cells and the bike or the other proteins as controls. And as you can see in this graph, the bike was able to activate the NKs and produce a killing rate higher than the NKs alone. So it proves that it was effective. And we repeated these experiments with the URCAT BCL-XL cell line that overexpress an anti-apoptotic protein, so they are less sensitive to apoptosis and also to chemotherapy. And in this case, the NKs were less effective to kill this target, but the bike retains its ability to activate them against the target. So that's all I wanted to say, and I will finish by thanking all of these people that are my lab mates and friends, and also thank you to you for your attention.
We have time for one question. I have a question. This is about the toxicity estimated for these kind of drugs to use in people, in patients.
Okay. For the moment, we have only done in vitro experiments, and we have tested if the protein was toxic for these cells, and we have seen that it wasn't. We haven't done any in vivo experiment, but we expected that it's going to be something very similar to monoclonal antibodies that are being used now in clinically most times.
Okay, but thank you. And we are going to continue with the next speaker. The next speaker is Andrea Moreno, and the title of her presentation is Targeted Immunotherapy for Pediatric Neuroblastoma Patients. Andrea.
Good afternoon, everybody. First of all, I wanted to thank the committees for selecting this work as annual communication, which consists of evaluating the role of neoantigens as immunotherapy for pediatric neuroblastoma patients. As you may already know, cancer is the first cause of disease, of death by disease in children. And as we can see here, despite leukemias are the most frequent ones, we can see that, we can see that the main cause of death is due to solid tumors, such as those located in the central nervous system. So we're focusing on neuroblastoma, which also has a low survival rate. And in order to decrease this mortality, we need more therapeutic strategies, such as immunotherapy. And in this regard, we're focusing on neoantigens, which are abnormal proteins caused by mutations occurring in the cancer cells that are presented by the matrix histocompatibility complex to the T cell, and are recognized by the T cell receptor of the T cells, which lead to anti-tumor immune responses. And as we can see here, neoantigens can be used to develop targeted immunotherapies, such as vaccines. So to develop this, we need to sequence the tumor tissue and identify these potential neoantigens. And we're going to focus in this part. So to do so, we're going to do this in silico, and we first have to analyze the mutations to obtain the mutant peptides to predict the neoantigenicity, and then we prioritize some neoantigens before doing experimental validation and developing treatments such as vaccines before using them in the clinical practice. So the hypothesis of this work was that neoantigens could be used as both biomarkers and therapeutic targets for pediatric solid tumors. And the specific objectives would be first to analyze the mutations and predict their neoantigenicity, and then to evaluate the role of these neoantigens in pediatric cancer by correlating them to patient characteristics and prognosis, and also to identify if we found any recurrent neoantigens and prioritize them for experimental validation. To do so, the methodology consisted on downloading clinical and genomic public data. And for this study, we selected patients with pediatric neuroblastoma. And with them, we analyzed the mutations, generated the mutant peptides, and used prediction tools to determine the neoantigenicity. And then we used other tools to evaluate other steps of the neoantigen presentation using different bioinformatic tools and prioritize those that were recurrent. So let's see now the results. As we can see here, we analyzed 180 mutations, and we analyzed then more than 1,000 mutant peptides, from which only 26% were bound to any HLA molecule. So we obtained 370 potential neoantigens. And what we did later is to select those that were found in more than one patient. So we obtained these recurrent neoantigens. As an example, I'm showing neoantigens occurring in MICAN gene, which is a driver gene in neuroblastoma. And as we can see here, highlighted in red, we have a peptide that passed all the filters of all the bioinformatic tools that we used. First, we can see that it showed affinity to an HLA molecule. We also can see that it had a high stability, the complex form between the peptide and the mantra-histocompatibility complex, and it also passed the thresholds for other tools that predicted cleavage and whether it would be transported by TAP proteins. And as we can see here, it is important to mention that MICAN is a driver in neuroblastoma, and it has also been found that this gene is often amplified in pediatric neuroblastoma patients, and this amplification is associated with worse prognosis. So it would be interesting to develop a specific vaccine for patients with mutations, or specifically this neoantigen in MICAN gene. Now, I would also like to show other recurrent neoantigens occurring in MBPF10 gene, which is a neuroblastoma breaking point family member 10. And as we can see here, highlighted in red, we can see 3 peptides that also passed all the filters of all the bioinformatic tools that we analyzed, so they could be used as potential neoantigens. And with this, we can head into the conclusions that potential neoantigens can be identified in silico using genomic data. Now, despite most of the neoantigens were private, some of them were shared between different patients. And I don't have time to show all the work that we did. It was in poster 166, so if you have questions, we can see later. And we also analyzed the role of neoantigens as prognostic biomarkers and conducted some spatial transcriptomics experiments. And with this, the conclusion would be that neoantigens could be used as biomarkers and therapeutic targets in pediatric solid tumors. And what we hope for 2044 is that personalized medicine could be a reality for all cancer patients. And to finish, I would like to thank all my colleagues, especially our supervisor, Dr. Sanz, our collaborators, the funding sources, and of course, your attention. Thanks.
Thank you very much. For the sake of time, we will not allow for questions. Sorry for that. Thank you very much. And I would like to ask Dr. Mais Motlak to speak about the novel blood test that can prevent colorectal cancer.
Hello everyone, my name is Mais and I am honored to present my master thesis titled Whether CD24 Can Serve as a Biological Marker Using a Simple Blood Test for the Early Detection of Polyps to Prevent the Development of Colorectal Cancer. This research conducted under the esteemed guidance of Professor Arber and Dr. Shiran Shapira at Sourasky Medical Center, Tel Aviv. So following all the findings in the previous studies and the previous presentations, and after successfully differentiating between healthy individuals and cancer patients, we decided to explore CD24's potential for detecting precancerous lesions, specifically polyps. So before delving into my research, allow me to provide some context. What is colorectal cancer, or in its other name, CRC? CRC begins in the inner lining of the colon and can spread to the anal canal. It's the second leading cause of cancer-related deaths globally, and in Israel is about 1,500 deaths according to WHO statistics in 2022. Risk factors include age, over 50 years old, genetic predispositions, IBD like Crohn and colitis, and syndromes like FAB and Lynch. What are colon polyps? Polyps are small clumps of cells that form on the lining of the colon. They're classified as non-neoplastic polyps that don't have malignant potential and neoplastic polyps that have a high risk of progression to CRC, like adenomatous polyps. Okay, good news that 2/3 of cancer deaths can be prevented, and CRC, one of the preventable cancers, and thanks to a slow progression that from polyp to CRC, it takes a lot of years, and thanks to early detection that significantly improves survival rates, and it's about 90%. Okay, in our lab, which has been researching CD24 flagship molecule for 3 decades, we explored whether CD24 glycoprotein could serve as an early detection biomarker for CRC detection. By the way, it's our lab. This is our lab. So what is CD24? Is it a game changer, as Professor Arber calls it? Let's see. CD24 is a glycosylated protein found in the cell surface. It's involved in many processes in the cell, like proliferation, like adhesion, and angiogenesis. And high CD24 levels are associated with various cancers, highlighting its potential in cancer diagnostics and treatments. It's worth mentioning that all our studies were conducted under GLP conditions, ensuring reliable and high-quality data. So how was our research conducted? Our cohort included 376 participants, divided into 3 main groups: healthy polyps with adenomatous and hyperplastic polyps, which sorted by size and number, and CRC patients. Using blood samples from Suraski Medical Center, we isolated white blood cells, we stained them with CD24 antibody, and we measuring CD24 levels using flow cytometry. So aim to examine the CD24 score in relation to participants' diagnostics, polyp types, and number of polyps. About the results, if we are talking about the diagnosis, that the highest CD24 was observed in CRC group, and it was significantly higher than healthy group. If we talk about polyps type, higher levels of CD24 were observed in adenomatous polyps, and it was obviously higher than healthy individuals. But when we're talking about polyp size, larger adenomatous polyps correlated with increased CD24 levels, and it was significantly higher than healthy group. In contrast, if we're talking about number of polyps, no significant difference were observed between patients with 1 polyp or more. It may be due to limited sample size. So I can conclude that the average levels of CD24 in CRC patients were significantly higher compared to CD24 levels in healthy individuals. And the highest CD24 levels were observed in large neoplastic polyps, that reinforcing its potential as a marker for advanced lesions. And our main conclusion was that we believe for future it may serve as a universal blood test as an aid and valuable tool to clinicians in the early detection of cancers. So now I will hand it over to Fatin, who will speak about the universal blood test for early detection. Thank you for your attention.
Thank you very much. And we will continue with the last speaker, that is Fatin Abed Elahi. And the title of her presentation is "The Dark Age of Single Organ Screening is Over. CD24 is a novel universal pan-cancer blood test for early detection of cancer."
Hello, everyone. My name is Fatin. I have completed my master's degrees under the supervision of the 2 in a million Professor Arber and Dr. Shapira at Tel Aviv Medical Center. And today I will present our work on the validation of prognostic CD24-based cancer screening liquid biopsy assay in cancer and healthy subjects. Let's see. So, Ved. Excuse me. will try. Okay, thank you. So, normally, human cells grow and divide to form new cells as needed. When cells age or damage, they die and new cells replace them. However, this orderly process may sometimes malfunction, leading to the uncontrolled growth of abnormal and damaged cells. These cells can form tumors, which can either be cancerous, malignant tumors, or non-cancerous, benign tumors. Currently, around 20 million new cancer cases are diagnosed each year globally. Around 10 million people die from cancer annually. As for today, there is no definitive cure for cancer, but we firmly believe that the best way to fight cancer is prevention. One of the most effective methods of prevention is screening, which involves the routine testing of asymptomatic individuals. Screening can seriously reduce the risk of severe complications and death. For instance, when we are talking about colorectal cancer, when it's early detected, the survival rate is around 90%. On the other hand, when it's detected at later stages, the survival rate drops drastically to 33%. We believe that the ultimate screening test should be a blood test. Why a blood test? A blood test is ideal because it's sensitive, specific, cost-effective, reliable, safe, simple, acceptable, and accessible by the global population. What is CD24? CD24 is a cell surface protein that is heavily glycosylated and encoded to the cell membrane via a GPI anchor. It plays a role in cell adhesion and signaling. It's consisting of 31 amino acids, and its molecular weight ranges between 35 to 75 kilodalton. It has high expression levels. High expression levels of CD24 have been identified in numerous cancer types. Professor Arber first started to explore this hypothesis of elevated expression levels of CD24 in colorectal cancer. Later, to expand our method to other cancer types and to simplify our method, we transferred to use flow cytometry. We start with a simple blood test. Peripheral blood leukocytes are isolated and stained with a specific antibody, CD24 antibody. All cells are analyzed using flow cytometry. Our cohort consisted of a total 1,279 participants, of whom were divided into two main groups, the healthy subjects and cancer patients. Higher level of CD24 have been detected in cancer patients compared to the healthy population. As for the cancer patients, it was also divided into three subgroups: diagnosis according to the primary site of origin, metastatic versus non-metastatic, virgin versus non-virgin. When talking about virgin cancers are actually patients who have not been treated or operated. Non-virgin cancers are actually patients who have been treated, operated, or both. We also detected higher levels of CD24 in 9 different cancer types comparing to the healthy population. When talking about the second group, the higher level of CD24 have been detected in metastatic cancers comparing to non-metastatic cancers. As for the third group, higher levels of CD24 have been identified in non-virgin cancer comparing to the virgin cancers, so we hypothesize that the virgin cancers will have higher expression levels of CD24 because of their larger and untreated tumors, but we believe that our cohort size may have influenced the results. Furthermore, a sensitive analysis showed that the gender, age, collection time, fasting versus non-fasting did not affect the significant differences in CD24 levels. And to conclude, our test is based on the expression levels of CD24 in peripheral blood leukocytes. Cancer patients expressed significantly more CD24 in their peripheral blood leukocytes than the healthy population. According to our results, the test is not affected by age or gender, and to serve as a universal blood test as an aid to clinicians in the early detection of numerous cancers. I want to thank you all for this opportunity, and of course for Dr. Shapira and Professor Arber for the guidelines over the years. Thank you so much.
Thank you very much. And with that, we will finish this session on time. Thank you to all speakers. Thank you for co-moderator. And we invite for the next and the last session. Thank you.
Please. Okay. Dear friends, due to technical reasons, we are moving the last session to the Aula Magna. And also the awards of these abstracts will be delivered at the end of the Congress, right? Thank you. Thank you very much.